Yes.
A few announcements. Assignment 1 is due tomorrow. And the assignment 2 will be available tomorrow, probably due in the middle of the spring break. And then right after spring break, I probably Sunday at the end of spring break, I'm close to the midterm exam. And it's due the Tuesday after spring break. Okay. Somebody may say, why are you giving me such a terrible time frame? Don't blame me. Because in the past, the midterm usually is in the middle of the late March, because we are required to submit the midterm grades to the DA program. That's what the requirements in the past many years. And this year we got a message, just a few weeks ago that we need to submit the midterm by March the 8th. Okay, so it's a last moment adjustment of the time frame. In any case, please stay tuned and keep checking your email. The assignment 2 and the midterm will be one attempt only. Okay, because I'm here for help, respond to email, and you can talk to your friends, talk to your classmates, check notes. And after all, you are a graduate student in a very selective program who will train you to be a significant part of the healthcare team. Okay, so it's going to be one attempt only. All right. I hope you I'm sure you're gonna understand. Have no problem. And okay. So let's just look at this table. Okay, this table shows the association between the depression, severe depression, and the C-reactive protein level in the body. Okay, anybody know what the C-reactive protein is? And what does that indicate? If you have an elevation of the C-reactive protein in your blood. Yes.
Does it have something to do with inflammation?
Inflammation, it's an indicator of the stress level, and it's entire body. If you are infected and if you're mentally stressed out, the C-reactive protein is associated with a later increased risk of many conditions, particularly cardiovascular disease. And this also partially explains why depression is a significant risk factor of the cardiovascular disease. Okay, so my first question is, based on this table, is gender an effect modifier in the relationship between the depression episode and the C-reactive protein level? Is gender an effect modifier in the association between major depression episode and the C-reactive protein level? Yes. Great. Okay, the answer is yes. Anybody can tell us why? Look.
Sorry. I have I'm sorry.
P-value and the magnitude. Great. Okay. So you will see that among men, during the first year following the depression, it is the C-reactive protein increased to the most highest magnitude. It's 3 times higher. Okay. But after the 1 year after the depression episode, there's still a trend. However, it's not statistically significant. The trend is still pretty obvious because it's almost twice likely to have an elevated C-reactive protein. Among women, based on this data, you can say there's no strong indication that there is a relationship between the C-reactive protein level and the depression. Okay, so as a general trend, okay, so the C-reactive protein after the first year after the depression, you can expect, the stress level is a lot higher. And as time goes by, people get adjusted, to that. Okay, that explains, the change in men. Okay, so there is, based on the data, the gender is an effect modifier in the association between the depression, major depression episode, and the C-reactive protein level. All right. Sampling, we're not going to talk more because this is a little bit too specific. A lot of slides, 37, 39, 40 is for your reading purposes. We're not going to spend overly amount of time to discuss this. Okay, 41. Okay, this basically tells you that the response rate is gonna determine factor for you to decide your sample size and when you sample people. For your study. Okay, for example, if you know that some topic of survey has a notoriously low response rate, you might need to sample a lot more people than what's the statistical requirement. Okay, for a particular example, a survey about sexual history, a survey about the HIV and their perceived social, stigma. For survey topics like that, you're going to expect a very low response rate. And when there's a very low response rate, prepare to sample a lot more people than statistically needed. At the same time, when you interpret your study outcome, take care of the selection bias, because people who refuse to participate in your study, chances are they're very different from people who actually participate in your study. We have discussed about those issues in our last semester for the most part. This is for, so the cross-sectional study, the advantages is inexpensive for common disease, should be able to get a better response rate than other study designs because, there's no follow-up. No loss to follow-up type of response. A relatively short study duration can be addressed to specific populations of interest. Okay, can be addressed to specific populations of interest. Cross-sectional study design, disadvantages. Unsuitable for rare or short duration disease, high refusal rate, those are more like, common sense, I'm not gonna. Any questions about the first, slide set? Any questions about that? Any of you honestly think that we are going a way too further than what you perceived that's required for the PA practice? And just be very honest. Anyone think, she's talking too much, and when we are just gonna be PAs, we're not gonna, PIs or large studies or anything. Just be very honest. You think yes, right? It's, anything honest, I won't be upset. Okay, just be very honest, and please keep in mind when you take the clinical classes, I believe it's your most interest. You are not gonna study what exactly required. Usually it's gonna be a little bit more, right? Right? Because if you study what exactly required, chances are most people are not gonna reach the maximum standard. So in any case, So case control and cohort studies, and today we're just gonna talk about case control studies and clinical applications, okay? So there are observational studies that lie near the middle of the hierarchy of the evidence. Although not ranked by as highly as RCTs, can provide strong evidence, okay? As a review, Michael? Michael?
C.
Answer is D. Answer is D. But that's close. That's close. So this tells you that in terms of, the nature of the study, what they can dwell on, okay? So case control study and cohort study, they are analytical study. Case report and case series, they are a lot more like, a descriptive. Cross-sectional and ecologic, they're really somewhere between. They can be either partially analytical or, descriptive, so they are somewhere between. So based on what I just talked about, anybody can tell us what is the most fundamental difference between the analytical study design and descriptive design? Anybody can explain to us what's the most fundamental difference between analytical study design and descriptive design? Yes.
Just descripting me that you are describing what you saw in the study, whereas analytic is more about the data you collected during the study, and you analyze that data, make an observation or conclusion.
Analyze the data, making observations and conclusion. You don't want to analyze the data in a case series study or in professional study.
That's what I would think. No. You want to make a conclusion just based on the data. You have to also look at the observational part of the descriptive part, whereas analytic is more about the data you collected during the time.
Let me give you a specific example. This is a case series report. Do you need to analyze the data in order to get this kind of outcome? No? Yes? There is also data analysis in those descriptive studies. So what is the most fundamental difference between the two? Gina?
You can use descriptive to determine the distribution of disease, and analytical to determine risk factors.
That's closer. That's much, much closer.
Or
Really close, but just don't worry, just be bold. I mean, just tell whatever. Have I ever made fun of somebody, say, give like a stupid answer or something? Look,
Is it that analytical can take more into account, like you can judge more in an analytical study about the cause or the risk factors or something?
that's much closer. Yes. So in analytical study, there is a clinical inference, meaning the clinical causal relationship. See, is this drug gonna lead to better treatment outcomes? Is this risk factor gonna increase the risk of the disease? Those are all the causal associations. In descriptive study, we provide the data. We talked about one-dimensional data, analysis. What is the prevalence, what is the incidence, but we do not have a data analysis based on at least two variables. Only when you analyze a bivariate picture, you can have some kind of sort of causal inference. Okay? Which are more important? Both. Of course. Without the descriptive data analysis, you can't conduct analytical data analysis. That's why the case report and case series provide excellent data for you to generate the hypothesis. Okay? The fundamental difference between the analytical study design and the descriptive design is the analytical study design, have a clinical causal inference. The descriptive design presents a picture of the disease epidemiology, one-dimensional, without any bivariate analysis. Prevalence, incidence. I hope this is clear. Okay. Okay, this is a bunch of multiple choice questions. It's a review of our last semester, but it's also gonna help you strengthen your understanding about the study types. So if anybody is able to answer both of those two questions, I give an extra point, 1 point. I'm gonna give priority to people who barely talked in the past. First one, yeah?
It's
B, D, and E. That's a perfect answer. And the second one?
Oh, I didn't look at the second one.
I said both of
I
those
have to do
two.
both, okay.
I think you already got 0.5. Okay.
What did she say?
B, D, and E.
The first one.
Yeah, why don't you?
Let her finish. Yeah, she's
And
still.
then the second one would be D and E.
D and E. Perfect. Okay, perfect. Okay, those are perfect answers. Okay, and the prevalence, obviously A cannot do that. B, yes, you can do, because prevalence is a cross-sectional concept. Okay, you can look at it like the prevalence of female gender in this class, prevalence of people who wearing hoodies in this class. Okay, prevalence of people who are right now eating in this class, and prevalence of whatever it is, a fresh 4-year degree graduate in this class. Luke, is Luke, is one of them?
One of them for what?
Or a fresh graduate from a 4-year degree.
No, I took a gap year.
Oh, I'm sorry, okay. Because I thought I'm sorry, yeah, and the prevalence, so why D and E can also be doable? Because a longitudinal cohort or clinical trial can be considered as multiple cross-sectional points. Guys agree? Like if I follow you guys in the next 3 years, at every end of year I say prevalence of people who are happy with the TA program, I can do a survey. Okay, so, and we have talked about the RCT and the cohort study are similar in that their analytical time frame is the same, their prospective nature is the same. Okay, so it's BCD. Okay, the second one, D and E are perfect, was discussed. D cannot do that. At least, a precise and estimate it cannot do because there's no time frame. For the incidence, you're gonna have to have a study, time frame. Why C cannot? I think because simply we discussed last semester, C in a case control study, there's no natural distribution of disease. Okay, so the answer, so I hope you can understand this on the. I'm sorry, I think you're gonna have to remind me of your name.
Catherine.
Last name?
Bella. Right above.
Let me check the attendance, by the way. Zineb? Here. Badem? Adam? Oh, I don't think he's here. Courtney? Julia Kong? Gianna? Brooke? Manda? David? Abbas? Thomas? Michael? William? Kevin? Catherine? Jenna? Margaret? Michael? Andrew? David? Christina? Tyler? Alex? Euro? Joa? Matthew? Paula? Thomas? So the answer, okay. So case control study is a retrospective cohort design and study subjects categorized at the beginning of the study with the outcome disease and without the outcome disease. Okay, that's a review of the framework. Okay, so cases selected based on objective inclusion and exclusion criteria. Incident cases are always preferred over the prevalent cases. We have discussed this multiple times why. And it's selected from reliable sources, as EHR disease registries. Controls it's possible to match control to the cases selected on the basis of various factors to ensure this do not confound the study outcomes. Okay. Case control pros and cons. Advantage is cheaper, quick, easier to conduct, good for disease with long latency periods, can assess multiple exposures, and good for rare disease. Disadvantages, retrospective, more prone to bias, can only assess outcome, disease, cannot establish risk, cannot establish prevalence. Okay, but let's talk about one specific scenario, an example of a case control study outcome. Okay, circulation. First off, this journal. Okay, if you as a future PA, if you are cardiovascular PA, and if you have an opportunity to publish in such a journal, that's a huge positive thing in your CV. Okay, because circulation is the most respected journal in the cardiovascular disease area. Okay, and so this study investigates the risk of suicide following myocardial infarction. Okay, so my first question is, if somebody had said, do you think you can conduct a cohort study to investigate this? Do you guys agree? Why or why not? Yes?
No, it wouldn't be ethical.
Wouldn't be ethical. Why?
Because if you're doing a cohort study of people, you're waiting to see if say one of the groups who aren't exposed to myocardial infarction, or well, the one that are exposed to the MI, and they have a risk of suicide. Actually, now that I'm talking about it, then no. Because I was thinking then you're gonna let them, like, if they're gonna say that they're having suicidal thoughts, like, you're not gonna be able to intervene, but you do.
Yeah, I think you have a good point. In this case, I would say it is ethical to conduct an observational cohort study, because in reality, if they told their doctor or nurses or PAs they have suicidal thoughts, they will intervene them.
Right.
But that's for their natural, disease treatment process. Any intervention that helps you to tackle a research topic is not the appropriate observational study design. But in both myocardial infarction and non-myocardial infarction people, they could have suicidal thoughts. They're gonna seek the psychologist, psychiatrist for their own health, for their own quality of life. So that's, so my question is, let's get back to the question, so is it appropriate or the best thing to do to choose a cohort study design, and why or why not?
I got it. Because those who are not exposed to the myocardial infarction, they can, like you said, they can also have depression, but for completely different reasons. So if you have two groups of people that are showing depression,
Mhm.
it's for different reasons. So it's going to be hard to account for, to compare it to myocardial infarction and depression.
I appreciate your
I'm just not having
points. It's okay. I
Okay.
appreciate your points.
That's fine. Never
It's okay. I understand.
Okay.
There are two reasons. Okay, both of them are pretty, significant. One thing, do you consider suicide events is a rare event? Somebody may say, no, because I'm working in a clinic. I've seen suicide cases, so many cases. It's the same thing why the case control study is a much better study to study the rare disease. Because if it's rare, if you're in a clinic, it's a great idea, setting for you to collect the cases. But if you want to follow people who are alive, to watch the chances for them to kill themselves. So in order to get a sizable people, like at least 100, how many people do you need to follow? 1 million? Because let's look at the suicide rates. National data. Okay. Oh, that's the most, that's CDC data. That's the CDC data. Okay, so what is the magnitude of the measurement? It's a single digit versus 100,000. So how many, if you have a cohort study, how many patients do you need to follow them over time in order to have a statistically meaningful data? Doesn't look like it's going to be doable, seriously. Okay. You may be wondering, what is the highest rate of the, of the suicide rate? Are you surprised about this? Between 45 to 64. That's a midlife crisis. Okay, that's a midlife crisis. Many people in this time period feel like everything got messed up in their life. Okay, they got a divorce. Their kids are not doing well. They have major problem in their employment. At the same time, their physical appearance, their physical health has declined. That's the time when they start to feel like the life really sucks. Okay. So that's an example. Why the cohort study is not it's not going to be doable. Because there are too many people need to follow. What is the other reason? When you conduct a cohort study, one major disadvantage is the loss to follow-up. In this case, even if there's plenty of people who you can capture suicide, what's the major impact? Because in this case, people who lost to follow-up are much more likely to commit suicide than people who stay in your study. Guys agree? Agree? How many people are saying, I'm going to commit suicide, but I want to show you, how I'm going to kill myself. Okay, so I'm going to stay in your study. When people try to commit suicide, the emotional status is that they would like to detach from the world. Seriously speaking, okay? So in this case, if you conduct a cohort study, the loss to follow-up is going to cause a very drastic bias underestimation of the suicide rates. Okay, so in this case, the cohort study is not at all a suitable time, the study design. Best is the case control study. The background, is acute myocardial infarction is a severe life event followed by an increased risk of anxiety, depression, low quality of life, and all-cause mortality. Okay, why is that? First off, if you had a heart attack, chances are you're going to be at a much higher risk of getting a second one compared to those people who never had a heart attack. Every time you had one additional heart attack, it will cause an increasing physical health damage to you. Okay? If you had 5 heart attacks, you're gonna, honestly speaking, statistically, you're gonna be really close to grave. Okay, one thing. Another thing is that the myocardial infarction itself is gonna significantly affect your functional status. Okay, so for anybody, an attack of myocardial infarction is a very significant health and mental health and physical health negative impact. Okay, so so the study is trying to investigate the association of myocardial infarction and suicidal plans. Okay. And systematic investigations are needed to further examine the association. Evaluate the association between myocardial infarction and suicide, taking diabetes, stroke, psychiatric illness, because those are all potential confounding factors. Okay, the data. Okay, first off, it is a population-based case control study. What is a population-based study? It means the study cases is not selected from a representative sample, but is a natural population from a political entity. Can be a city, can be a state. In small countries like those Nordic countries, can be an entire country. Okay, the Nordic country, as a matter of fact, is an excellent study to have a population-based study. Why? It's small. It usually is highly socially, economically developed countries. Therefore, every citizen from cradle to grave, okay, their employment status, their marital status, their socioeconomic status, and their healthcare seeking, utilization history, disease diagnosis are very well kept in those Nordic countries. It is very challenging for countries like US to do the same thing, because first off, it's such a huge country. The population is highly heterogeneous with totally different kind of healthcare plans. Okay. At the same time, the immigration rate is really high. In many cases, an illegal immigration, and they don't even have any health insurance and records. Okay. So that's why this kind of study, is best to be conducted in countries like Denmark. Okay. So in this particular study scenario, all newborns have been followed from cradle to grave in Denmark with a unique ID. Okay. So nationwide longitudinal registers in Denmark. The cause of death register provided information on suicide from 81 to 2006. The Danish National Patient Register contains the diagnosis of all non-psychiatric conditions. The Danish Psychiatric Central Register has all the psychiatric conditions. The Danish Integrated Database for Labor Market Research has all the socio-economic data. Finally, the ICD codes were used to ascertain disease cases. I would assume by now you have all worked with the ICD-9 codes. I think as a medical script and as I'm sure you're familiar with the ICD codes. So why it is much better, it's not an acceptable thing in a healthcare setting to just write the diagnosis without specifying the ICD codes, because the ICD codes, by looking at the specific decimal and specific number, you can tell the exact disease diagnosis without any potential for misdescription. For example, cancer. Okay, the stage, the type of the tumor, the type of the cancer, it can be very precisely expressed with the specific ICD-9. Okay, so it is required. Actually, it's required. Okay, to in all the healthcare systems in the U.S. to diagnose and record a disease, we use the ICD-9 code. In all the developed countries. Okay. The cases were persons aged 40 to 89 and recorded with the suicide in the cause of death, registered from 1981 to 2006. Controls is 25% of the population matched by sex and exact age. Okay. Statistical methods used the conditional logistic regression model. The odds ratio as a proxy of incidence rate ratio. Okay. When the event is rare, the odds ratio equals to the relative risk. Just remember this. I can easily prove that, but I don't think that for the nature of these classes, it's not the emphasis to really prove. But just remember, in the future, in the rare disease cases, the odds ratio approximate relative risk. Okay. Major risk factor study is a diagnosis of acute myocardial infarction. Okay, analysis suggested for marital status, labor market status, annual income, history of psychiatric illness, history of stroke, history of diabetes. These are all potential confounding factors listed above. Okay. The first table shows you, are there any significant differences based on the table between cases and the controls in terms of their age and sex, the distribution of their age and sex? Are there any significant differences based on the study design, what's said in previous slide, and the data? Are they supposed to be? Yes.
There are more men who had cases of myocardial infarctions, and then also those who were between the ages of 40 and 59. Those are the ones that you saw the most cases.
That's true, and they're not supposed to be different because cases are matched with controls by age and gender. So they're not supposed to be different. Okay? The second one, all right. Let me ask a question. Okay. Based on this table, can anybody tell us, does myocardial infarction significantly increase the risk of suicide based on the table, overall, in the overall population? I'm going to ask a few questions based on this table. One. Did MI significantly increase the risk of suicide? In the overall population? B, if the answer to question 1 is yes, what is the approximate magnitude of increased risk of suicide among MI survivors? 3, is gender an effect modifier to the relationship between MI and increased suicide? T. The MI affects what age group the most in terms of elevated risk of suicide?
Okay, none of those, I mean, most of those questions are not exactly straightforward. But I'm gonna give whoever answers this question an extra point of 2 if you're able to answer all of those questions.
But I'm hoping that when you answer the question, you're gonna try to, do as best as you can.
Let's wait until 2:40. I mean, those questions, I don't think that's too much for TA as a profession, Anybody can help us, can do this? I'm hoping that when you really talk, you know, you're gonna be able to. Yes,
Say one yes, so
the
then
answer is yes. The second one,
40%? Or 20%?
about 25%.
Okay, just, okay.
About 25%. You guys know the difference between adjusted and unadjusted. In this case, do we need to look at the adjusted outcome or do we need to look at the unadjusted outcome? Huh?
I'm gonna guess adjusted now.
Adjusted, okay. I tell you what does this really mean, okay? I tell you what does this really mean. Adjusting for the association between A and B with all the potential confounding factors, okay? I give a particular example. In this case, the relationship that you try to study is myocardial infarction and the risk of suicide. So, for example, why the employment status is an important confounding factor? Because the employment status, the unemployment is a risk factor of committing suicide. Guys agree? Okay, guys agree. Okay. Do you guys also agree that among people who are unemployed, they are more likely to suffer from myocardial infarction? Many reasons. Lack of health care, okay? You know, lack of health care, for example, somebody previously had hypertension and is receiving regular treatment, and now he's suddenly unemployed. Okay, lack of health care, being depressed. Okay, so in this case, chances are, okay, people who had a myocardial infarction are more likely to be unemployed. And unemployed are more likely to get suicide. So what you need to do, but your real purpose is to tease out all those potential confounding factors to see the true relationship, the net impact of MI on the risk of suicide. So you need to tease out the confounding effect in this case. So after you adjust for this kind of confounding factor, you're gonna expect the magnitude of the increase will decrease. But it's not all the case that after you adjusting for confounding factor, the magnitude will decrease. In some cases, it might increase. But in this case, you just need to look at the connections and use a common sense. Okay? That's why the unadjusted magnitude is about 40%. After you adjusting for all those confounding factors, it gets down to 25%. Okay, so the second question, the second is about 25%. The third answer?
No,
Why?
because the
Why not?
rate for male is the same as overall, and the female rate's slightly higher, but like not.
But which p-value should you look at? 64. 0.64. 0.64 testing the interaction term of sex in myocardial infarction on the risk of suicide. So if it's not statistically significant, it means there's no significant effect on modifying, impact. Okay? So the second answer is no. The fourth.
48 to 49.
Perfect. Okay, so it means myocardial infarction affected the younger people more in terms of their quality of life and a subsequent risk of committing suicide. Does it make any common sense to you guys? Just one second. Does it make any common sense to you guys? Of course it does. Look, if I get a myocardial infarction, I will be a lot more depressed than people who are in their 70s. Because why? Because I never had a heart history. I don't even have hypertension. I'm still expecting to go upward in my career, have a lot of things to do to my family, to my friends. Why the heck do you think I should be pretty much, I'm defunctioned when I'm not even 50 years old? Okay? for somebody who is a retired granddad, his life is all set, okay? And he probably had at least one of the chronic conditions, you know, he's more prepared. Okay, so that explains, you know, why it affected the younger people more. So I think he answered most of the questions correct, you know. I think he should get 2 points. What's your name?
Matthew?
Sorry. Which one?
Yeah, small.
Okay, so I'm hoping that it is more clear, you know, it is clear to everybody. I think I have a question, yes, Danielle.
So, for the first answer, how can you say yes if there's no p-value to it? Like, there's no p-value for the overall population on the chart, so why are you saying that it's significant?
What do you mean? P-value to the overall population?
Like, the way that I was trying to look at it when I was doing it was, I was looking at the p-values, but for like the all column, there's no p-value associated with it, so how are you
Oh,
able
I
to say
see.
that it's significant?
That's a good question. Any of you can answer the questions? Good question. We have talked about this in the first few lectures. That's a great opportunity to review what we talked about. Yes,
Is it because the null doesn't include one?
exactly. Where the 95 confidence interval does not include the null value, it means the p-value is is less than 0.05. Because it means you repeat your estimate 100% of the times. Chances for the p-value to include the null value is less than 0.05. It means it equals to the scenario that, you know, the factor that the effect is greater than 1 is more than 95% of the chance. It means the chances the effect is due to random is less than 0.05. Okay. Anybody have questions about the clinical implication that we can draw from this table? I hope this is clear, and I honestly don't think this particular table is too specific for the, for future practice. Okay. I think I'm gonna have trouble to get back to the original surface. I'm gonna click this, don't save, and then open again. Okay, so I hope this is clear to everybody, This, I think, is a little bit too specific, okay, for the scope of this class, So this basically tells you that, investigation of the impact of suicide risk, by their psychiatric disease, disease status, okay, and by the time when they are, So, can anybody tell us which subgroup of patients their suicide risk increased much more compared to the other after the myocardial infarction? With psychiatric disease or without psychiatric disease?
with psychiatric disease. Okay, so this makes sense, because after the myocardial infarction, it can exacerbate the existing psychiatric condition, which can further contribute to the risk of killing themselves. Okay. And I think this one, according to age, this, again, it's the more severe than with psychiatric condition. I'm not gonna talk about this because I think this is a little bit too specific. Despite the specific psychiatric disease conditions, we can see affective disorder, schizophrenia, and other psychiatric conditions. You see, among the 3 types of psychiatric conditions, affective disorder, schizophrenia, and other psychiatric, the impact is about the same. Okay. Overall, the younger patients are more likely are more affected. Okay. So the study conclusion is that the adjusted RR of suicide for persons with myocardial infarction compared with persons without myocardial infarction was 1.24. Okay, 1.24. 1.24. The RR of suicide was the same for men and for women, no effect modifier. The risk of suicide was the highest in the first month after discharge for myocardial infarction. First month. First month. Recall the C-reactive protein level, and it tells the same. Increase mostly during the first year depression. Okay. It means our human body, as time goes by, we gotta adapt it to a change of the situation. Okay. We're gonna adapt it to the change of situation. Okay. So those are the additional findings. Strengths, large sample size, population-based study, and a high quality of data. Okay. Weakness is unreported psychiatric mild illness, limited generalizability, particularly in third world countries. Okay. So that's the conclusion. In this population-based study, we found a higher risk of suicide in patients with myocardial infarction that was not explained by the stroke, diabetes, mellitus, psychiatric illness, or socioeconomic factor. The RR of suicide was particularly high shortly after discharge, tended to decrease with age, and tended to be particularly high among persons with known psychiatric illness. Question: which group of patients need the most medical attention in order to prevent suicide? Last question based on the data that we discussed. Abbas?
Okay. No. C.
The answer is C. Okay, the answer is C. How many of you guys don't agree? Younger patients who just had a myocardial infarction. Okay. Any questions about what we have talked about?
questions about the study and, other questions about the assignment 2 and the midterm exam? I hope it's clear, you know, if you need anything, just email me. As I always say, I cannot promise, but I usually respond to email really fast. And let's communicate, keep the communications on. I don't think anybody's gonna come here and strike. I will back that.